So we've heard about and talked a lot about the stages of change model, Prochaska and DiClementi's model for understanding patient readiness to make important changes in their lives. Mm-hmm. And I guess the first question, Ted, is why is this important? And what does this do for the primary care physician or other provider who's trying to work effectively with patients in chronic pain?
I think what we found is that using this model, this stages of change model, from the perspective of the physician, saves a tremendous amount of time because it helps us with our patient education intervention towards the end of an interview. It also helps with focus. If I know that a patient has a certain stage of readiness for behavior change, it helps me focus my intervention. And third, I think it really avoids burnout. If I understand that a patient just isn't ready to make a change in their life yet, it's easier for me not to try to fight with them in order to make them make that change. It's easier for me to accept them where they're at and then work with them over time, as opposed to spending all day going like this with patients.
So it sounds like that kind of targeting of where the patient is in their own minds in relation to chronic pain is not only helpful for the patient, but it really helps to focus the physician's attention on how best to have that discussion and what sorts of things might best be addressed in the interview with the patient.
Yep.
So briefly, tell us, what are those stages of change? What are we talking about when we ask about readiness to change?
Well, it can be broken into many different levels, but for practical purposes in primary care, we think about 3 stages or 3 flavors. You know, patients come in 3 flavors, chocolate, strawberry, and vanilla, or 3 stages of readiness. Pre-contemplation. The patient who's pre-contemplative doesn't have a hint of a whiff of a clue there's a problem, and they're not about to do anything about it today. And that's typically about 30% of patients. About 30% of smokers are delighted that they're smoking and aren't ready to do anything about it. About 30% of patients with high cholesterol don't think it's a problem and aren't going to do anything about it. About 30% of patients with chronic pain are not willing to entertain anything different. So that's the pre-contemplators, about 30%. I don't have a problem, and please get out of my face, will you? Contemplative. The middle group are the contemplative group, about 40% of patients, and those are patients who are ambivalent. They're of 2 minds. Part of them says, yes, this is a problem, and I probably ought to be getting ready to make some change. And part of them is saying, oh, you know, I've tried it before, and it just hasn't worked. And so that's an ambivalent group that's in the middle.
They're on the fence.
It's about 40%. Yep. And then finally, about 30% are ready for action or ready for change. They are waiting and just almost internally begging for some guidance and for some shepherding in how to implement change in their lives. And those are people who are ready to take action. Interestingly, the treatment plan is totally different with the 3 different stages. For patients who are pre-contemplative, the treatment plan is relational. Maintain the relationship, agree to disagree, and continue to encourage them over time. The treatment plan for people who are ambivalent, people sort of in between, contemplative, is educational. Those people thrive with education, not asking them to make the change, but educating them more about the reasons for change. And finally, the third group, the people who are ready for action, the treatment plan with them is behavioral. You can carefully negotiate with them what actual changes they're going to make in their lives, and then monitor them carefully to be sure they have the support they need to implement those changes.
So, Ted, I think that when we are dealing with chronic pain, the pre-contemplator is a little bit different than the person that smokes or has high cholesterol, right? At least my experience is that they come to you in a very passive manner. Help me fix the pain. What are your thoughts there?
Yeah, I think you have a very good point. A patient who's pre-contemplative is a patient who internally isn't ready to make any changes.
Yeah.
They may accept the fact they have a problem, chronic pain, and please help me. You fix me so I can lay around on the couch and get better.
Correct.
That would be a very passive but very pre-contemplative patient with chronic pain. Another example of a patient with chronic pain who might be pre-contemplative could be a patient who's on opioid pain medications with chronic pain, who is delighted that they're on opioids and is pre-contemplative about getting off of those opioids. And you as a provider might be sort of leaning towards trying to get them off. But whichever it is, the person with chronic pain who's pre-contemplative is going to resist a change in the treatment plan and often expect others to fix them.
So it sounds like a very useful, practical kind of delineation of patient types, I guess, if you will, who are coming to see you. How did you go about assessing who's in which of these categories? How do you define a pre-contemplative versus a contemplative patient, for example?
So from a practical standpoint, especially in terms of the biobehavioral model of chronic pain management that we're really focusing on here, you would sort of present a hypothesis to a patient and then listen carefully to their response to decide whether it sounds pre-contemplative, I don't want to do anything, contemplative, gosh, I've got a problem, but I don't know, or ready for action. So for example, you might say something like, the biobehavioral model is an approach to your pain which will be really useful. It's going to require some change on your part. It's going to require us to work closely together. I'm ready to help you with a plan on how to begin to implement a biobehavioral model when you're ready. But this can be hard to hear. I'm wondering what your thoughts are. And then you listen. And the pre-contemplator will say, oh, no, none of that works.
Yeah.
A contemplator will be, yeah, I wish I could do that. I so much want to get better, but I don't know if I can bring myself to it right now. And a person who's ready for action may well say, oh my gosh, I've been waiting for some guidance on how to try to take control of this and move forward.
So this really is kind of a spectrum from the reluctant or even dismissive patient at the pre-contemplative stage to the potentially open to trying new strategies at the other end of the spectrum.
Yes, it's a continuum, and the key from a clinician standpoint is if I hear a pre-contemplator, I know my treatment plan is relational. Maintain the relationship and then build on that relationship to encourage openness for education. When I hear a contemplator, my treatment plan is educational. Time to educate this person and follow up with them fairly regularly. And then my treatment plan for a person who's ready for action is negotiating a behavior that they think they can change and then following up with them extremely closely so that you can reinforce it, support it, and try to avoid them relapsing back and going back to disenchantment and pre-contemplation again.
I like the idea that with the pre-contemplative patient, your approach is truly relational. You're spending time validating their complaints and establishing the kind of rapport that it sounds like later can lead nicely into your own ability to help move them through to the more accepting and open stages of change.
Yes.
Yeah. So how does this work in pediatrics? Do these same stages apply to the pediatric population?
Same stages, a little bit more complicated because we have the child or the adolescent and we have the parents. And many times they are both in different stages. The child or the adolescent is in the pre-contemplation stage and the parent is more ready for change. And that in part is due to the emotional immaturity of the child, and the lack of ability to realize that pain is not just a sensory problem, but there is an emotional component. So for an adolescent, it's very hard to separate or to understand the concept that there is an emotional component to pain and that they need to take ownership of that.
You know, it sounds like what you're saying is that on some level the parent needs to be helped to do the very same things we're trying to get physicians to do in the pre-contemplative stage. Go back to emphasizing and validating their pain and focusing on the relationship as opposed to the challenge or encouragement that may be coming at the wrong time for their child at that moment.
You are correct, Jeff, and I'm sure that as a psychologist, you face this a lot, that many times produces a lot of friction between
Sure.
parents and children, much more when the parents are really ready for action and the child is refusing to get up from bed, and mom and dad have to go to work, and they hope that the child will get up in the morning and start doing something,
Yeah.
and they come back at 5 p.m. and the child never get up from bed. So the interactions are much more complicated there.
And so you introduce this concept to the parents in terms of trying to reorient the approach they're taking.
Correct.
Yeah, it's kind of you're moving them into a greater synchrony with their child.
Correct.
Yeah.
And teach them also
Very
that
good.
they need to understand that, okay, you may be ready for action, but your child is not.
Yeah.
And that's where referring them also to work with a psychologist helps a lot.
Very good. So what we've learned today is that there is an importance of understanding stages of change as outlined by Prochaska and DiClementi because it helps to focus the provider's time in their appointments with their patients on the readiness for the patient on some level to engage in the discussion, on their readiness to hear a validating versus an educational versus an action plan set of steps. We've learned that these are the three stages we're talking about: pre-contemplative, contemplative, and action, and that each of these stages creates an opportunity for providers to target and focus their intervention on what might be most appropriate. We've learned a little bit about how to extract that information, how to listen carefully to patients, to begin to get a sense about where the patient falls on this continuum of readiness to change. And we've learned that we use this information then in targeting our approaches, validating at the pre-contemplative stage, educating a little bit at the contemplative stage, and preparing a plan of action at the action step. Finally, we've learned that in the pediatric population, we have to assess both the child and the adult and help the adult to sync up with their child in much the same way we're trying to help practitioners make sure that they're engaging at a point in this process that their patient is ready to resonate with. And sometimes it can become a little more complex in the pediatric population because now this is a three-way conversation as opposed to a two-way conversation.